Great. Please do scream out if you don't see my slides or if they're
We
not.
see it.
Thank you. Fantastic. So thank you so much for inviting me to speak today. It's my great pleasure to be here, and it's been a really huge pleasure and honor to be working with Ian, who was so foundational and so helpful through the process of the guidelines development, and also working with Theodora on this general topic more broadly, and really connecting on rural health issues more broadly with her. So it's really a great honor and great pleasure to be here. As many of you know, as Ian has just alluded to, WHO in the May has launched the updated rural guidelines, or rural health workforce guidelines, which speaks to the development, the attraction, the recruitment, and the retention of health workers in rural and remote areas. And you may also know that 2021 is the International Year of Health and Care Workers, and through this year, we have been having three main messages around health workers, which is to protect those health workers who are in place, to invest in those health workers who are in place, but also invest in creating more capacity, ensuring that we have the health workers we need to meet health needs everywhere, and then acting together. So making sure that we do this in a participatory way, in a way that brings everyone to the table who has contributions to be making. So that is really the stage in which we're starting from. And I wanted to quickly give a little bit of context here. Let me see, it's not moving forward. There we go. Of course, Ian and Taya have spoken to some of these issues in terms of context around the needs in health care workers in rural and remote areas. So almost half the world's population are living in a rural or remote area. As Theodora said, there is very high rates of extreme poverty in these areas. But what we see is much less than half of the world's health workers are located in rural and remote areas. So some recent data that we've done for the State of the World's Nursing Report show that around only 1 in 3 nurses were located in a rural and remote area. And we have seen some reports in some contexts where access to health workers is 10 times lower in rural and remote areas compared to urban counterparts. So this means that health workers aren't located in accordance to population. So this is that the number of health workers are not related to where the population is, or where population is. But there's also a question around it, and this is sort of what Ian was referring to at the top, around needs, right? So are health workers located where they are needed? So what we see is indeed there's distributional inequality, and this is both when we just look at headcounts of health workers, headcounts of people, and then also when we look at more deeply, when we look at the kinds of health workers, where they're located, the kinds of needs, the complexity in health needs in different areas, and we see that there's a mismatch. And we estimate that this mismatch could translate into somewhere in the range of 2 billion people. So this is a huge number of people who don't have access to essential health services where they are. So this is a major global health issue. And so foremost, we want our health workers in rural areas to meet the needs of the population, to deliver primary health care, to deliver upon our commitments to universal health coverage. But we also recognize the larger contribution of the health worker. So how improving access to health systems, to health services for areas where the concentration of the world's extremely poor has a clear and very important role to play in our global goals, notably our global goals to eradicate extreme poverty, how the health sector and rural pathways can contribute to ensuring inclusive and equitable quality education and promote lifelong learning opportunities for all. And you'll see in the guidelines, there's a lot that speaks to this and the opportunities for rural health workforce development to contribute to those broader global goals around education. How, if we recognize and we value the unpaid voluntary health workers, but also the unpaid healthcare that's done in homes and in rural communities, and how much of this care is being done by women, there's clearly a key opportunity for the health sector to contribute to women's full and effective participation. in economies, which in and of itself would be a contribution to development-oriented policies that support obviously productive activities and decent work creation, decent jobs. And the health sector has a key role as well, and we talked to this a little bit in the guidelines, on protecting labor rights and promoting safe and secure working environments. So this really speaks to one of the key areas for the International Year, which is to protect our health workers. And we've really seen through the COVID-19 pandemic the importance of ensuring that our health workers are protected. So there's a clear role for reducing health inequalities, of course, but also a clear role with reducing inequalities both within and among countries. And this is a little bit of what Taya was talking to just before. So there's a policy imperative here. So governments have committed to act. So we have several instances where governments have made commitments. They've made commitments to, of course, the Sustainable Development Goals. There are commitments through the Global Strategy on Human Resources for Health. We had a lot of evidence come out in acknowledgement of the High-Level Commission on Health, Employment and Economic Growth. Of course, there's the Astana Declaration, and there's the relatively recent UN high-level meeting on universal health coverage. And all of this really creates a strong platform for change, and it sets really a time frame for this action that needs to take place. So the first reaction then to the question that we're here thinking about, which is this a pipe dream, is there seems to be political commitment, right? So we see that there's some political commitment in this space. So that's number one. The other thing that we see is that there is a huge amount of new evidence coming to the fore on what is working and what is not working in terms of interventions in health workforce in rural and remote areas. So as I said, we've updated these rural guidelines. There's a first iteration of these rural guidelines that came out in 2010. And that first iteration of the guidelines was based on and included 27 studies. The full evidence base for the updated guidelines includes, of course, those 27 studies and brings us to 133 studies. So there is this systematic review that is an update was done from some colleagues that you might know working in this space, including being led by Sarah Strasser. And what we saw is that the evidence base has grown. So it has grown in several different ways. It has grown in size. There are many more studies. That's almost a 5-fold increase in the number of studies that were included in the evidence base of the guideline. But they're also have grown in terms of what they cover. So we've seen a larger number of countries covered by the evidence base. We have seen more evidence from low and middle income countries. I think you can see that in the 2010 guidelines, more than 70% of the studies were from high income countries. That has come down to 57%. So we're seeing a diversification in where these studies are coming from. We're also seeing a difference in terms of which kinds of health worker occupations are covered by the evidence base. So in the 2010, again, 70% of the studies were on doctors, and now we have much more evidence coming to the fore on nurses, on midwives, on community health workers, on dentists and pharmacists and allied health workers and others. So we're seeing a growth in terms of what we understand, where we understand it, and how and who it applies to. So the second part is that there seems to be evidence in this area. So we have political commitment, and now we're seeing that there's evidence. So the guidelines, they are based on this evidence. They're also, so that's the systematic review that goes in. There was also a survey of stakeholders. There was another systematic review, a smaller systematic review looking at different aspects of the of the inputs in terms of feasibility and acceptability. And we have the updated guideline, which has 17 recommendations that cover education, regulation, incentives, and personal and professional support for health and care workers in rural and remote areas. All of these 17 recommendations are tied together by a good practice statement, which really stresses the importance of bundling these interventions so that we ensure that the interventions are interconnected and that they address the wide spectrum of factors associated with health worker locational choices, and ensure that health workforce distribution and the ensuing, essentially, health workforce distribution. It also stresses the importance of for policymakers to consider elements such as gender, equity, and rights, along with the roles and responsibilities of health workers and rural communities, and how policies might impact upon these different groups, upon potentially men and women differently, on different age groups differently, on different classes, ethnicities, and so forth. So it also outlines an overarching principle of a participatory approach. And I'll quickly run through these recommendations, but I know that I've taken some time, so I'll do this really very quickly. So the recommendations are in 4 key areas. There are 5 recommendations on education, which include student selection. It includes the location of training. It includes aligning the education with the rural health needs, so that there's diverse health needs in different communities, and we need to really align the training to this. And then facilitating continuing education and that link to lifelong learning for rural and remote health workers as well. There's another set of 4 recommendations that cover regulation, and these are in terms of scopes of practice. They're in terms of the different kinds of occupations that might be needed to meet rural health needs. They are terms to how we go about if we're enacting compulsory service to ensure that they are actually respecting the rights of health workers as well, and how we tie education subsidies to agreements for returns of service for rural and remote areas. There's one recommendation around incentives. So this is to provide an attractive package of incentives that influence or that can influence decisions or locational decisions. And the remaining recommendations are around personal and professional support. So these include elements such as the living conditions, safety and protection, decent work, support networks, career pathways, knowledge exchange, and the profile of rural health workers. So there's a set of evidence-based policy recommendations. There's an evidence base, there's political commitment. And in the guidelines and the summary document to accompany the guidelines, we lay out a framework essentially for dialogue and action. So that really puts forward and illustrates the participatory approach to health workforce policymaking in rural and remote areas and how essential this is. So if we look at this holistically, what we have is we have the political commitment, the evidence base, the policy recommendations, we have a dialogue and action framework. A lot of the elements that we might want to make health workforce distribution more equitable seem to be there. So really bringing us to the core question that Ian posed and that we're really trying to think around and address. I think that what we see is we've seen political commitment. We've seen this mentioned. We say we can pull this out in particular declarations and commitments. There are interventions there that address different kinds of policy levers. They're intersectoral policy levers. They're holistic. These are all based on evidence. We know that it's really important to have dialogue. And that this, that all of this is around the recruitment, the retention, the development, the attraction of the areas. We know that there needs to be some action taking place. But then there's this M. So if you're reading this down, I'm trying to write pipe dream out on the column, but there's this M. And so what is the M? What is the missing piece? Because we do see that right now we are quite far from achieving distributional equality or distributional equity amongst health workers. So what's missing? If we have political commitment, we have interventions, we have policies that appear to be effective, we have guidelines, we know the path we might need to take, the commitment is there. What is the M? And I'm thinking a little bit around political will. So if you think around political will is often defined not just as intention, so lying out a commitment or the intention, but it's actually the motivation behind that. So is the motivation that missing piece? And I'll leave that for you to really think about. So in conclusion, it's the political will and that action, the political will and action that are needed at all levels to turn these commitments that we've seen to action, the policies that we see that have evidence behind them, the levers, into realities. We need to see this coming through in terms of whole of society approaches. We need that investment we're talking about in the International Year of Health and Care Workers to allow us to develop a health workforce who are fit for purpose in rural and remote areas. And only when we have that will, only when we have the motivation to turn all this into pragmatic action to make changes, are we going to actually be able to achieve, I think, all of many of the SDGs. I count, several that are reliant on us achieving this and ensuring that nobody is left behind. Thank you.